Today everyone, we are from Group AA and we will be presenting the case for our ambulatory care attachment. The patient is Mr. RG, 61 years old. He is obese with BMI 35.9 kg per m². His chief complaint is non-stop coughing for 1 week and history presenting illness are hypertension, hypercholesterolemia and GERD. He took telmisartan plus HCZ for hypertension, esomeprazole for GERD, atorvastatin calcium for hypercholesterolemia, bromhexine HCl for cough, and paracetamol for pain relief. There are two drug-related problems we detected. Firstly, inappropriate dosage regimen for bromhexine HCl. According to NIMS, the recommended dosage regimen is 8 to 16 mg TDS, but the patient is prescribed as 8 mg OD. For the management, we can discuss with the doctor and suggest the frequency of bromhexine HCl to be changed from OD to TDS basis. Second, side effects associated with long-term use of esomeprazole. Prolonged use of esomeprazole, particularly more than 1 year, might cause higher risk of fundic gland polyps, osteoporosis-related bone fracture, hypomagnesemia, vitamin B12 malabsorption, and subsequent vitamin B12 deficiency. As management, we can monitor the signs and symptoms of these side effects in this patient, and if these side effects occur in this patient, we should reassess the need and use of esomeprazole.
Diagnosis and clinical condition of the patient are hypertension, hypercholesterolemia, GERD, and coughing. Evidence to support the diagnosis of hypertension is firstly obesity. Obese individual is more susceptible to hypertension, and secondly is the age of the patient. The patient was diagnosed with hypertension when he was 56 years old, where high blood pressure is more common in older people because arteries get stiffer with age. And lastly is the concomitant chronic disease of the patient, which is hypercholesterolemia, that will increase the risk of developing hypertension due to accelerated atherosclerosis. As for hypercholesterolemia, first, obesity can lead to hypercholesterolemia due to increased fasting plasma triglyceride, high LDL cholesterol, and low HDL cholesterol in obese individual. And secondly is the age of the patient. He is 61 years old, and older population tends to have higher chance of getting hypercholesterolemia. As for GERD, the patient is obese, and a meta-analysis concluded that obesity is associated with increased risk of GERD due to the increased intragastric pressure that cause reflux of acid gastric content into esophagus, resulting in heartburn.
So for the recommended treatment for hypertension, hypercholesterolemia, and GERD, all of it is appropriate for the patient. Meanwhile, for the cough, it is advisable to change the frequency of bromhexine from OD to the TDS basis. For the evidence to support the recommended treatment for hypertension, it is shown in the CPG that the diuretics and ARB have been shown to reduce cardiovascular events in elderly. Diuretics also shown to enhance the efficacy of other classes of antihypertensive drug. And because patients have hypercholesterolemia, so the combination therapy is preferred in this patient.
A drug evaluation by Schneider in 2014 proved that the combination of telmisartan and hydrochlorothiazide provide significantly greater reduction in 24-hour mean blood pressure than the other combinations. These combinations are also found to be effective and well tolerated in the elderly patients.
Meanwhile, for the evidence for hypercholesterolemia, statin treatment has shown to be clearly documented to reduce CV events in all age groups, irrespective of the baseline LDL. The low-dose atorvastatin in medium-risk hypertensive patients also shown to have significant reduction in CV events because patients have atorvastatin 20 mg, which is the moderate intensity statin therapy, so it is shown to lower the LDL on average by approximately 30 to 50%.
The use of atorvastatin 20 mg for hypercholesterolemia caused significant reduction of LDL cholesterol and is more cost-effective than the 10 mg. According to RJG and Welty in 2008, atorvastatin 20 mg is generally well tolerated in the elderly population more than 60 years.
For the GERD, from the ECG guideline for diagnosis and treatment of GERD, it is shown that long-term PPI therapy is extremely beneficial in patients with chronic or complicated GERD, and also reduced dose PPI have constantly proved ineffective for long-term management of GERD.
Studies by Calabrese et al. And also Johnson et al. found that the continuous or long-term PPI therapy is particularly useful in elderly patients with GERD to obtain a profound acid inhibition and to maintain complete symptom relief and healing of esophagitis. Lastly, a review by Zanassi et al. In 2017 served as the evidence to support the use of TDS or 3 times daily use of bromhexin per cup. This treatment can cause the effect on glycoprotein fibers in sputum and also cause a decrease in sputum viscosity. In fact, the lowest therapeutic dosage that is ever reported in bromhexin clinical study was found to be 15 mg for 24 hours.
So these are some of the other relevant pharmacist intervention that we can do. So firstly, we can find out who manages the patient's medication, because the patient is elderly and he may be associated with dementia, and that can affect his patient's medication adherence. Next, we can find out if the patient is having trouble to obtain medications, such as if the patient is having financial issues. Then we can suggest for the patient to elevate the head of the bed when sleeping to help managing his GERD symptoms. We can also remind the patient to not lie down or sleep directly after meals, because this can exacerbate his GERD symptoms. We can also counsel patients to control his diet, as it is beneficial for his hypertension, hypercholesterolemia, and GERD. We can also suggest some light exercises for the patient to increase physical activity and to help in weight reduction. And lastly, we can educate the patient on symptoms and management of hypertension to reduce the risk of falls in the future.
Monitoring plan of drug therapy for hypertension. Blood pressure of the patient should be monitored daily to ensure the goal of therapy is achieved. And for safety, monitor for any adverse effects such as hypertension, diarrhea, electrolyte disturbance, and acute renal failure. For drug therapy of hypercholesterolemia, lipid profile of the patient should be monitored frequently to ensure the efficacy of the therapy. While for safety, monitor the signs and symptoms of myopathy and rhabdomyolysis by looking at the serum creatine phosphokinase level. Other adverse effects such as diarrhea, nausea, constipation, and blurred vision should be monitored as well. For drug therapy of GERD, monitor the signs and symptoms of GERD such as heartburn, chest pain, and dysphagia for efficacy. While for safety, we can monitor the level of magnesium periodically, as the patient is on concomitant use of hydrochlorothiazide, which may increase the risk of hypomagnesemia. That's all from us. Thank you.